Yeah. Good evening, ladies and gentlemen. On behalf of Microlabs, I, N.K. Raja, Vice President, take this opportunity to welcome all distinguished faculty, chairpersons, and delegates from across the globe for today's third annual Congress of Regain, which is primarily the excerpts from EDTA 2020. Before we start today's event, let me share the highlights of yesterday, which was day one's program. We had excellent feedback by audience for content and deliberation. We had overwhelming participation with a registration count to close to about 400 plus, which is a challenge in regular symposiums as well as CMEs. And we were also able to reach almost to all corners of the world, and happy to share that we had participants from many countries, including US, UK, Middle East, as well as Asia Pacific, African countries, South America, and as well as India. So thanks to the technology, which will enable us to connect today to over 500 plus delegates who are already registered. So before we further move on, I have the honor of welcoming Dr. Manjula, who is our Vice President for Medical Services, to take over the session and give a brief intro about Microlabs. Over to you, Dr. Manjula.
You're on mute, ma'am.
Yeah.
We can hear you, ma'am.
Yeah. Can you see my slides? Yeah. Yeah.
Full screen, ma'am.
Yeah, right.
Yeah.
Good evening, everyone. Sorry about that. Once again, welcome you all to day 2 of third annual Congress Regain. I am Dr. Manjula, welcoming you on behalf of Microlabs and Micro Knowledge Academy. To tell you briefly about Micro Knowledge Academy, it's an independent, non-commercial body supporting educational and academic activities. It is committed to conceive, build, and sustain program and make scientific initiatives which are aimed at providing evidence-based update to healthcare professionals. It engages eminent doctors from various for scientific activities. And some of the ongoing activities include Fever Foundation of India, which handles the manages unmet needs in the fever management across the specialty. So we maintain hypertension registry in association with Indian Hypertension Society. We do entrain live surgery workshop in association with the Otolaryngology Society of India, glaucoma registry, and all of you are familiar with this Regain postgraduate program, which is successfully running for postgraduate students in nephrology. And we maintain e-library and patient education programs as well. So today we are here on day 2 of the program. You can see the very, very exciting sessions today. To conduct this session, to moderate this session, we have two eminent nephrologists chairing this session. Both of them do not require any introduction. I'll be doing it as a formality. So it's my proud privilege to introduce the chairpersons of today. The first chairperson is Dr. Vijay Kher. He's the chairman of Nephrology, Kidney and Urology Institute at Medanta. He has more than 40 years of clinical experience. He has set up successful nephrology department at Sher-e Kashmir Institute, Medical Sciences, Srinagar, SGPGI, Lucknow, Apollo Hospital, New Delhi, Fortis Hospital, New Delhi, and Medanta, the Medicity, Gurgaon. An astute clinician, a teacher par excellence, keen researcher, Dr. Kher has more than 180 publications in peer-reviewed journal, has delivered more than 350 lectures at national and international scientific events. He has been awarded fellowship by National Academy of Medical Sciences, Royal College of Physicians, Edinburgh, and Indian Society of Nephrology. He also has his credit clinical fellowship nephrology at University of Cincinnati Medical Center, USA, and research fellowship hypertension at Henry Ford Hospital, Detroit, USA. He's an inspector for DNB and DM recognition for National Board of Examination and Medical Council of India. He's a recipient numerous awards and accolades across the field of nephrology. His specialization and expertise include clinical immunosuppression, ABO incompatible transplantation, paired exchange donation, steroid-free immunosuppression. So, Professor Dr. Vijay Kher, it's a pleasure to have you with us. It's a privilege also. And once again, welcome to you for this program, sir.
Thank you.
Our second chairperson is our Lieutenant General Sir, Dr. Prem Prakash Verma, Dr. P.P. Verma. He is a director currently the Venkateshwara Hospital, New Delhi. He is alumnus of Maulana Azad Medical College, did his DM nephrology from PGI Chandigarh. He did fellowship at Massachusetts General Hospital, Boston, MRI Hospital, Atlanta, and Toronto General Hospital, Toronto. He has been honored with fellowship of Indian College of Physicians, American College of Nephrology, and Indian Society of Nephrology, American College of Physicians, Royal College of Physicians, and National Academy of Medical Sciences. He's been actively involved in the teaching graduate, postgraduate, and postdoctoral student. He superannuated from Indian Army after long 37 years after attaining the rank of Lieutenant General. He's been honored with Ati Vishishta Seva Medal, and Vishishta Seva Medal by the President of India. He has contributed more than 200 presentations, more than 60 published articles, and 12 chapters in textbook. He has been practicing medicine for the last 30 years and nephrology for past 25 years. He's been associated with over 1,000 renal transplants. He's been awarded NB Alumnus Award for the year 2014 for his outstanding contribution to nephrology community. He's been the honorary surgeon for President of India. And we've been working for this, and whatever you are seeing, this Congress is the hard work of Dr. P.P. Verma and Dr. Balla. And then you always, whenever we call, personally have seen him always smiling face. I've never seen him without smile, sir. Most welcome to you. It's an honor and pleasure to have you with us, sir. I request you to kindly take over the proceeding and start the proceeding of scientific session today, sir. Thank you very much.
Thank you very much, Dr. Manjula, for very kind words. And actually, myself, Dr. Bhalla, and Dr. Manjula, we scanned all the data from EDTA, and whatever best we could filter out, we must have spent a lot of time. It is not a complete EDTA, but whatever is the best possible good experts, which were of practical value, that we selected and we are presenting. This is the second of the 3 series, and we have got galaxy of very astute teachers and speakers today. To start the talk, we will go to Dr. Anand Vardhan, and it's a pleasure to introduce him. He is from Manchester. He is a consultant nephrologist and renal clinical director, honorary senior lecturer at the University of Manchester. He is also associate of General Medical Council PLAB examination. He is associate hospital dean for last 5 years at Manchester Medical School. It's a pleasure to say that he belongs to India, and he did his graduation from AFMC, Armed Forces Medical College, and subsequently he spent a lot of time in Delhi doing his research and residency. Eventually he shifted over 25 years back to UK, where he did his MRCP specialist training in renal and general medicine at Mercery Deanery, and then he went for MD research in Manchester Royal Infirmary, and for good around 4 to 5 years, from 2002 to 2005, where the basic stress was on cardiovascular medicine. His special areas of interest are peritoneal dialysis, diabetic nephropathy, and today he is talking to us on whatever is new are the recent advances in the field of peritoneal dialysis with reference to whatever has been covered in EDTA 2020. Over to you, Dr. Anand Vardhan, and once again I welcome you. It will be a pleasure to listen to you.
Thank you so much, General Verma. That's a very generous and kind introduction. I'm almost embarrassed. I hope my talk stands up to scrutiny. Thank you, Dr. Manjula, for seeking me out, and to Mr. Raja for organizing. Let me go to the talk. So I'm also grateful to you, General Verma, for your guidance on, outlining the talk. So I shall jump right into it. So these are advances in peritoneal dialysis as discussed and as brought out at the recent ERA EDTA conference in Milan, which I had planned to attend, but couldn't for obvious reasons. So my disclosures, there are no current disclosures, but in the past I've received honoraria and advisory
Your
board
slides
positions.
are not coming.
Oh, I apologize.
Your slides are not coming.
I apologize. There must be a way of.
Share the screen.
Once again, you need to share it.
Right. I think my Zoom screen is playing up. That's very strange.
Are you seeing a small video there, sir, on the right side?
I'm not seeing any of you.
Then it is minimized. The Zoom is minimized in your system. You have to maximize.
So maximize, and it is not maximizing for some reason, which is very odd. I apologize for this. This shouldn't happen.
You'll get this option for maximizing it.
Is there a small video, a small window on the right?
Yes, I have found it now. So I can share screen. Right. We will get there. Thank you so much for your patience. Can you see my screen now?
Yes, sir.
Yeah.
Yes.
Can you start from the first slide, sir?
Yeah, the first slide is just the title. My apologies. So picking up quickly, so my disclosures, there are no current disclosures. In the past, I've received honoraria from various firms and been on advisory boards. So the talk is structured in two halves. The first half is actually a review of the relevant sessions from the ERA EDTA conference in reference to peritoneal dialysis. And the second half is perhaps just a few reflections and perspectives which are local to us and which we have personal experience of, some of it unpublished. So these are the sessions that I've highlighted here, which were relevant to peritoneal dialysis. There was a silver plenary talk on PD access by Victoria Briggs, followed by a talk on incremental dialysis, optimal PD access by Ollie Heinberger, then how to stimulate PD programs by Simon Davis. Then there was a talk by Jorinda van Lanen on the PD catheter complications, and then interesting talk on the gold plenary in the pearls section on monotherapy for PD peritonitis. And then there were free communications, which I have highlighted here in smaller text. And this is, and I will only mention these because there won't be time to talk about these, but I would invite you to log into the EDTA pages where you can find more interesting stuff about this. So it talks about DPP-4 inhibitors and their effect on preventing peritoneal fibrosis. There's a combination of crystalloid and colloid in peritoneal dialysis, and then the role of streptococci in peritonitis, and then a report from Spain from Bell and Marin about the PD mortality and hospitalization from 2018. So we'll just focus on the bold ones at the top, which are the relevant. And then we'll follow it up with our perspectives from Manchester on peritoneal access procedures, troubleshooting malfunctioning catheters. As far as PD for acute kidney injury in COVID-19 is concerned, I was having a conversation earlier with the panelists. So you may have seen reports now from New York and from London in various publications about the use of PD. In Manchester, we did not require, we had adequate facilities for CVVH and for intermittent hemodialysis in our intensive care. And therefore, when we did have the surge of COVID-19 and the AKI associated, we were able to manage without using peritoneal dialysis. So I will leave it at that. And then a little bit of work that we are involved in the early diagnosis of peritonitis, which we developed here in Manchester. So moving on quickly to the PD access talks. So the information here is sort of adducted from all the talks, and it's not specific to any speaker. So this was a publication which is about 10 years old now, and it came out in the American Journal from a group of surgeons, no doubt. And they referred to placing a PD catheter as not being rocket science. Well, if you read what they had to say, placing PD catheters is not rocket science. Any resident at the PG Year 3 level should be able to learn this by reading a book. And perhaps we should use that as a measure of ability to progress in residency. For the love of God, let's not require a teaching curriculum for PD catheter placement. Now, I think those of you, and I think I'm addressing a very informed audience who are involved in the day-to-day care of PD patients, know that probably PD catheter placement is one of the most complex, simple procedures. And I think this term was used by Victoria Briggs, and not only her, but many others. And I think we recognize this. And it's not just an exercise of stuffing a tube inside somebody's belly, but actually an appropriate patient selection, patient preparation, appropriate selection of technique for that scenario, the selection of appropriate tubes, and then having adequate experience so that the procedure is carried out smoothly, appropriately, and then you have a catheter that is useful in the end and remains useful for a significant length of time. So the entire chain and sequence of events is actually important, and therefore it may not be rocket science, but it is still not a simple procedure. So this slide is from the UK Renal Registry, which shows you on the left-hand axis, this is a funnel plot, which shows you on the y-axis PD catheter failures, and on the x-axis the size of the dialysis unit. So small units on the left here with about 20 or less patients, and larger units on the right-hand side. The data is not complete. As you can tell, we have more than 100 PD units in the UK, and reporting is not complete. But you can see the display of data points on the left-hand side is quite a lot. So if you have very small units and you do not have adequate experience, therefore you may have a disproportionately large number of dysfunctions. You could be a unit that does better than average if you have very few patients, but equally you could be a unit that does significantly worse. But as you move along the mean to the right-hand side, you will find the bigger units where the practice is more uniform and is closer to the mean. So I think what it basically tells us is that experience is extremely useful. If you're running a very small unit, then you may have extremes of success or failure, and it takes, so whatever techniques, whatever you do, if you do enough of it, then you learn and you do it properly. So on the right-hand side, you see the causes of PD access failure in 1 year. And again, I must point out that there's a lot of missing data here. So that actually makes things difficult to interpret. But if you look at the top here, 3, laparoscopic, open surgery, and percutaneous, and 3 colors show you loss due to infection, catheter malfunction, or leaks and hernia. And I think across different procedures, there's not a huge difference. So I think that the message is that whatever you do lots of it and you'll do it well. So here's the next reference was to the ISPD guidance, which has come out last year. And this is about creating and maintaining optimal PD access. It is definitely a paper worth reading and reflecting on, and actually comparing your practice with what is being recommended as standard practice. But I think the key thing here is this table that I will just spend a few moments on. So this is a suggested guideline for selecting a peritoneal dialysis catheter insertion approach. So if you have a patient that is suitable for general anesthesia, but they've had previous major surgery or peritonitis, then the most highly recommended procedure would be advanced laparoscopic. If you don't have access to that, then perhaps open surgical dissection. Now, if this patient has not had any previous major surgery, again, the most suitable and appropriate would be advanced laparoscopic insertion, or next would be image-guided percutaneous or open surgical dissection or peritoneoscopic, and last, percutaneous without imaging. If you have a patient, on the other hand, who's only suitable for local anesthesia, there may be cardiac issues, multimorbidity, extremes of age, then open surgical dissection under local anesthetic would be most appropriate. Or if they've not had any previous major surgery, they could have image-guided percutaneous or open surgical again, peritoneoscopic or percutaneous without image guidance. Now, this is a grid which gives you general guidance. It's by no means prescriptive. And I think we all have to look at what facilities. We may not have a setup where advanced laparoscopic procedure is available. And I will talk about this in a few minutes. We may actually be limited by what facilities we have on offer, and also experience really matters. So if you've been doing a certain procedure and you have experts in that direction, then that would be the technique that would be used. So moving on, more about catheter placement technique. So this is a Cochrane review from Hatay et al., which was published last year. And so they've done a meta-analysis. Actually, this is a repeat of what they did in 2004. And this is about catheter type, placement, and insertion techniques for preventing catheter-related infections in chronic PD patients. So we know that in spite of all the progress that we've had, peritonitis is still the main limiting factor. So I think that's why this analysis was based on peritonitis. So there were 42 studies which involved more than 3,000 participants. They looked through 18 techniques of implantation. There were 22 different catheter types in question. However, the study design did not completely fulfill the consort standards for reporting. However, so this is what they found. So the main endpoint was peritonitis, and others which they looked at was exit site infection, technique failure risk, but they looked at laparoscopic procedures versus laparotomy. They looked at subcutaneous burying of the catheter versus not embedding. They looked at midline incision versus lateral incision. They looked at percutaneous versus surgical insertion and straight and curly caths. And they also looked at the standard curved Tenchkov versus the swan neck tube. So they basically found that there was no significant sort of difference in technique failure in any of these. So really, it is very difficult to say that a particular procedure is the best in general terms, and what is best for one may not be for another, and what is best for one setup may not be the best for another setup, and it's all dependent on your experience. Then we have this from Badri Shrestha from Sheffield. This is a meta-analysis of advanced laparoscopic peritoneal dialysis catheter insertion compared with others. So this was a meta-analysis of 7 cohort studies, totaling more than 1,000 patients. So the outcome measures that were looked at was obstruction, migration, leak, hernia, infection. So all the sort of things that we as PD physicians worry about. So the comparison was made between advanced laparoscopy versus open insertion. So what they found was the incidence of obstruction and migration was significantly less if you employed advanced laparoscopy. However, catheter survival and all other parameters were very similar in both situations. So what is advanced laparoscopic procedure? I mean, it is quite possible that you may have access to this within your setup. So an advanced procedure involves adhesiolysis where it is required, omentectomy or removing redundant bits of omentum, omentopexy, which is fixing bits of omentum to the back of the anterior abdominal wall to stop it from actually getting entangled with the PD tube, epiploiectomy, salpingectomy, and sometimes colopexy. So I have to say that we have limited access, although we have highly expert laparoscopic surgeons and we do laparoscopic insertion repositioning in our center, but we have limited access and experience of our operators to this. And included to that is the method of rectus sheath tunneling, which gives the tubes a sort of a memory or a path so that displacement is prevented. The next one was a study about comparing straight versus coiled catheters. And I'll really seek your attention on this because this has taken me by surprise. And this is from Chow et al. From AJKD last year. So this is a multi-center, open-label, randomized controlled trial with a mean follow-up of up to 21 months. So they compared straight catheters versus coiled catheters. Now, I don't know about your centers, but we used to use straight catheters up until the year 2000, 2001. And something happened in UK at that time. And I think most centers moved to using coiled catheters, double cuff coiled catheters. I was certainly not in a position of making decisions at that stage. And this seemed to have happened. And I'm not sure what the evidence was for the move. So they found that the drainage failure was actually significantly less. As you can see, there are fair numbers of patients in both the straight group, 153, and the coiled catheter group, which is 155. So there seemed to be a significant difference between the failure of drainage. However, if you look at it, I mean, in both categories, the success is quite good, actually. If I have a catheter that lasts this long and has drainage failure so infrequently, I'll be actually quite happy. So I think although this difference is statistically significant, whether it is actually significant enough for implementing in your practice, that needs some more reflection. The other points came as a surprise. So there was similar peritonitis risk in both groups, which seems reasonable because both tubes have two cuffs and they are not any more different. But there was a higher infusion pain in coiled catheters. Now, you might explain this in many ways, but from a patient's comfort point of view, if both catheters function equally well, and if there is even a slightest suggestion that a straight one functions better, then why would you inflict your patients to infusion pain? So therefore, I think this is a time for reviewing practice. And I think I'll be taking this to our governance group to say whether we have adequate evidence here to change practice again. So we've gone around in a full circle in that case. So we changed to curly cats in 2002, and then we might change back to straight ones. And this is the survival plot that shows the sort of difference between the straight and coiled catheters pretty soon after insertion, and that difference is sort of maintained through the entire follow-up time. So the next one was to talk about mention of the self-locating versus straight PD catheters. Now this is very interesting because I have to admit I have no personal experience with these self-locating. So you can see there is a little photo here of the catheter, which has a sort of a tungsten cylinder which is present at the tip. So it gives a 12-gram extra weight at the tip so that it seeks the deepest part of the pelvis once inserted and then stays there. So this randomized control trial had 32 straight tension cuffs and 29 self-locating catheters. And you can see on this graph, the two lines actually separate almost immediately, with the self-locating catheter performing fantastically with a straight line. And so it was the unweighted catheters which required replacement, 7 of these, and they were all replaced by weighted ones. And then once that was done, I think there was a pretty straight line. So again, this is telling us something quite significant, I think, and worthy of reviewing our clinical practice. So to end this section, then I just wanted to summarize the ISPD recommended audit measures, which I think all of us are probably already doing, and I'm sure we are. And those of us who aren't should be considering doing this so that we can actually match our performance and our outcomes with other centers and look for areas of improvement. So there should be catheter patency at 12 months. So if you've had advanced laparoscopic placement, this should be more than 95%. For all other techniques, you should have more than 80% catheter patency. For exit site infections and tunnel infections, these should be less than 5% at 30 days. Same for peritonitis, less than 5% at 30 days. Incidence of visceral injury, which includes bowel, bladder, or solid organ in the process of putting the tube in, that should be less than 1%. And any bleeding which requires transfusion or a second intervention, again, less than 1%. So we're moving on to the next section, which was actually quite interesting. This was presented by Jorinda van Lanen. She is actually a vascular surgeon from Stockholm. It is extremely difficult to capture her talk because a lot of it was in videos, and I would invite you to log into the EDTA website and actually have a look at these videos because they're actually very interesting. And so she made reference to this publication from 2017, Rataichak, and this is basically a table which tells you about the early and late complications, surgical complications largely associated with the PD. I think an informed audience is familiar with all these. There is nothing really new. So what was new in that presentation was there were videos of tethering the PD catheter to the back of the anterior abdominal wall with a metal stitch. Now, you might be alarmed by this. I think our surgeons are certainly not up to doing anything like this. And there were a lot of questions from the panel as well as from the audience about what do you do when you want to remove this tube. And she felt that it could simply be pulled out, and the stitch was actually quite loose. There were also videos showing us the procedure of omentopexy, and that'd be an interesting watch. So moving on, so this is the UK catheter study, which should give you more information on what constitutes success. So 45 participating United Kingdom facilities have now completed a recruitment period of 30 months. The data gathering is done in December 2017. We should be expecting results very soon. Our unit is involved in this analysis, and it will give us some insight into which process of actually acquiring PD access actually works best. So we look forward to that report. So the next one was an interesting one on monotherapy for peritonitis. So the standard ISPD guidance suggests combination of antibacterial agent for gram positives and another one for gram negatives. So this was a study from Thailand involving 8 centers. So it was a multi-center open label, non-inferiority randomized controlled trial. So they used cefepime, which is a 4th generation cephalosporin. They had 69 patients in that arm, and in the standard combination therapy, in which they use cefazolin and ceftazidime, they had 73 patients. So they basically used CAPD, and every single exchange had the antibiotic. They reported success at day 10, unlike day 5, as we use in our part of the world and as recommended by ISPD. They confirmed non-inferiority and therefore recommended that monotherapy with this 4th generation cephalosporin is actually a suitable alternative first-line intervention. In the same journal, actually, there is an excellent editorial which actually does a very critical appraisal of this study. So apparently, cefepime has neurological complications. It is renally excreted, and there may be complications alluding to that which had not been touched upon. The other thing is the cost of therapy. The third is the frequency. So if every single CAPD bag is going to have the antibiotic, that may have implications for cost. It may have implications for how many patients can actually do that. So there are advantages with the conventional vancomycin and amyloglycoside. And therefore, this sort of a study, the study needs further analysis and understanding, but it's useful to know, and it's a scientifically well done project. So this actually cartoon gives you a summary. Essentially, I will not dwell on this because I've already given you a summary of what the findings were. So it was not inferior, and it's definitely worth considering. So quickly coming to the latter part of my talk. So at Manchester in the UK, we have a very long history of delivering peritoneal dialysis. And the professor under whom I came to work, who was the president of the ISPD at the time, Professor Ram Gokul. So in the year 2000 and 2002, when I joined, we had more than 300 patients on peritoneal dialysis therapy under his care. And I learned the craft of PD under his supervision. So we, until 2011, our center was a transplant surgeon-led PD catheter insertion service, which functioned really well. But during this time, there was a massive expansion in our transplant services, and transplant surgeons became very busy doing what they should be doing. So in 2012, we developed this physician-led PDC insertion under local anesthetic technique. So we started off with Seldinger technique, which is relatively simple, but actually it limits the type of patients that you can choose. You have to be very careful that they've not had previous surgery, and because the wires and your instruments are pretty sharp, and you can puncture bowel and you go in the wrong places quite easily if you're not careful. So after the initial year, we moved on to the Y-Tech insertion technique, which is from the United States, which basically facilitates the use of a peritoneoscope. Now, it is much talked about. There are many centers that use that. However, our experience was that under local anesthetic with mild sedation, when you insufflate air into the peritoneal cavity, it is quite painful in the recovery phase. When the patient sits up, some of this air actually finds its way under the diaphragm and can be quite painful, and the patient's not very happy afterwards. So we had to modify that. So we currently have a modified, adapted, minimally invasive technique, which we use. So initially this was single-handed, but now we have 3 operators so that we can offer a service through the week. And this is backed up by a team of 12 transplant surgeons, should there be a problem. So these are our PD numbers over the years, over the last 10 years. We're running somewhere around between 80, 85 annually. At the moment, we are close to 100 because thanks to COVID, there is no transplantation and patients are actually collecting on dialysis therapy. So if we translate this back, we had more than 300 patients, some of whom were inappropriately perhaps on PD because we were underserved with hemodialysis. So this slide shows you the profile of procedures. The blue line shows total number of PD catheter procedures that we've carried out since 2013 when we started collecting data on our activity. So the orange line shows you the medical procedures, and the gray line at the bottom shows you surgical insertions. And you'll see 2017 was a very active year, but in general terms, the medical insertions are actually now more common, and that's the standard way, and the surgical insertions are being needed less and less. This slide tells you the orange, the yellow bit in the center tells you about the number of medical insertions that we're carrying out, and you can see that it's gradually expanding. The blue bit on the top is the surgical insertions, and at the bottom, the light blue and the orange are the repositioning procedures that we've required for malfunctioning tubes. I won't dwell into this slide, but basically it is showing you the complication rates, and I can tell you in summary that the catheter failure and infection rates are in line with international reports, and therefore we are comfortable with that. So concluding now with a little story. So we talked about this 63-year-old male who had bladder carcinoma, which required radical cystoprostatectomy and cystoplasty. He used intermittent self-catheterization. He'd had a previous road traffic accident with fracture of pelvis and a previous inferior wall MI. Also had a history of pyoderma. So he came into end stage and we carried out.
Dr. Anand, we'll request you in next 2 minutes.
Yeah, thank you. So, so basically we took him for PD catheter insertion, which was done successfully, and the PD process worked well until we ran into some problems. So on this left panel, you can see there is an abdominal X-ray. The PD catheter is hard to see. You can see previous surgical clips in place, and the PD catheter is coiled slightly high, but the coils are not under strain, and these were working fine for almost 2 months. Here you can see is a fairly lean gentleman with a very clean and superficial tunnel and exit. So we've located the PD catheter deep cuff, which we then tried to pull out. And this catheter was stuck to omentum. So it had to be gently teased off. And when we withdrew the catheter out, we found, so there is an organized clot within the coils of the catheter. So the clot was obviously removed. The catheter straightened with an Amplatz stiff wire and then reintroduced. And then this catheter is back working. So it was carried out as a day procedure. He went home the same day and he's back on dialysis straight away. Another similar case, which shows you, again, this catheter was displaced and it went up, and you can see there's a fair amount of fecal loading as well. So possibly patients who either choose not to or find it difficult to take laxatives. Again, the catheter was pulled out and the clot removed, and here you can see it's working well. And then repeat X-ray shows the catheter is back in the pelvis. Perhaps the projection is not ideal, but perhaps so long as it functions, we are not too fussed. So we've introduced a process of heparinization of our catheters. There is a passing reference in the ISPD guidance about the use of heparin, and I think it is worthwhile considering, especially if you come across this problem of catheter clots inside the catheter, which make them stop functioning. So I will conclude now with just 2 more slides. So I'm involved with this research work in conjunction with the microbiology department at the university, where we're developing a device. And you can see here on the right-hand panel. So it's a device with 3 chambers where PD fluid, spent PD fluid collects after the PD exchange, and you leave that to sort of incubate by the side of the machine. And over a period of 6 hours, the color change in these channels indicate whether you have a gram-positive, gram-negative infection, and whether there is a significantly elevated white cell count in the PD effluent. So this device is currently on trial. We have around 8 units within the UK. We are testing these. So you can see on the left-hand panel, there is a color change on the white cell count chamber. So these are bags that have been taken out of the device. It will be inside this device on the right. So we are currently recruiting, and we are hopeful that this device will be able to pick up infection before it becomes clinically manifest, and we may be able to address this one cause which causes PD failure most often. I think I'll stop here. Thank you so much.
Thank you so much, Dr. Anand. And I think the whole crowd will agree that they couldn't have asked for a better exposition of EDTA excerpts. And given your personal experience has added flair to the talk. Thank you very much. It was wonderful. It was wonderful. And we are leaving the question answers till the end. So you will have to wait for another 45 minutes or so, and then there'll be a combined question answer session. I think we will shift to the second speaker, that is Professor Kher. I think Dr. Manjula has already introduced, and Dr. Kher does not need any introduction to any Indian nephrologist. He is the brightest star on the horizon of Indian nephrology, a most sought after nephrologist in India, a very pleasant teacher and very fond of teaching, and a very keen researcher. Actually, he is teacher of teachers, a brilliant academician and a clinician, and more importantly, an excellent human being. He's a very mature nephrologist, and as a matter of fact, he has been my examiner and Dr. Kuller's examiner in DM exam, and he loves teaching. I think we will hand over to Professor Kher to go for the next talk, that is Arni, which is again a highlight of the conference. Over to you, Professor Kher.
Thank you, General Verma, for that exorbitant sort of introduction. Thank you very much for that. I do not deserve all that praise that you launched on me. I hope you can see my slides.
Yes, we can.
Are you able to see my slides or no?
We can see the slides.
Okay. The angiotensin receptor neprilysin inhibitor is actually a paradigm change molecule which has come over the last 4 or 5 years in the use of cardiologists. And those nephrologists who do not have cardiology department in their hospitals actually may not be aware of this molecule. Actually, angiotensin receptor inhibitors we use very commonly. Nephrologists are using it for prevention or progression of chronic kidney disease, ACE inhibitors and angiotensin receptor blockers. But this neprilysin is actually an enzyme which metabolizes natriuretic peptides in the body. And natriuretic peptides, because of instant neprilysin, the neuroendopeptidase which catalyze these and degrade these products. So the half-life of natriuretic peptides is extremely small. But when you use a neprilysin inhibitor and then you can increase or prolong the half-life of these natriuretic peptides. So this drug actually potentiates the combination of angiotensin 2 receptor blocker, which has valsartan, and sacubitril, which is a neprilysin inhibitor, which is the neuroendopeptidase inhibitor, which increases the natriuretic peptides in the body, and therefore that leads to vasodilatation, natriuresis, diuresis, whereas the beneficial effects of angiotensin T1 receptor, like decreasing vasoconstriction, increasing sodium and water, or decreasing sodium and water retention, and decreasing fibrosis and hypertrophy. So you take the advantages of the neprilysin inhibitor as well as the RAS inhibition by combination of valsartan with sacubitril, which is a neprilysin inhibitor. And therefore you have the effects. And this drug actually sort of is a paradigm change in the management of heart failure. The paradigm trial, which was published in New England Journal of Medicine a few years back, and the cardiologists sort of have started. And the reason why the nephrologist should also get interested into this is that combination of heart failure with chronic kidney disease is extremely common, is not an uncommon combination that you see. Majority of our patients have cardiac disease. And in fact, even in those patients who do not have an obvious patients of chronic kidney disease and dialysis is cardiovascular disease. And many of them will have heart failure. This diagnosis is underdiagnosed in patients on dialysis. The reason being that most of them get diagnosed with fluid overload, which is fairly common in our patients. So heart failure is defined as a clinical syndrome in which patients have the following features. Usually symptoms of breathlessness, and you can see that why this diagnosis will be missed, because breathlessness is fairly common in our patients on dialysis. They have fatigue, tiredness, and ankle swelling. So you can see these symptoms almost are similar symptoms to patients with chronic kidney disease. Usually these patients may have typical signs of tachycardia, tachypnea, pulmonary rolls, pleural effusion, raised jugular venous pressure, peripheral edema, and there is objective evidence of either a structural or functional abnormality of the heart. Actions of the heart would be, if it is called HFrEF, if the ejection fraction is less than 40%, it is sort of measured ejection fraction is more than 50%. And ARNI is the drug which is being used in the paradigm trial in the HFrEF, which is ejection fractions less than 40. The stages of heart failure are that you have progressive decline in the function and structural changes in the heart, basically. Cardiorenal syndromes, most of us are aware about, and this is impaired kidney function during heart failure, and combinations of that. You can have acute kidney failure or acute kidney injury in patients with acute heart failure. You have acute kidney injury in patients of chronic abnormalities or chronic, and then acute worsening of heart function in patients who have cardiac dysfunction, chronic cardiac dysfunction. And then type 4 renocardiac syndrome is basically that you have high incidence of coronary artery disease in patients who have chronic kidney disease. And type 5 cardiorenal syndrome is common conditions which cause both renal as well as cardiac, like amyloidosis or diabetes mellitus would be one of the commonest causes of chronic renal failure in these kind of settings. And you can see that the incidence of heart failure increases in patients who have chronic kidney disease. And so this is incidence of systolic and diastolic dysfunction in patients who have those without chronic kidney disease. And as you can see, through the stages of chronic kidney disease, there is an increasing incidence of chronic kidney disease, heart failure in these patients. And this is that 30 to 50% of patients with heart failure will have some form of renal dysfunction. So EGFR less than 60, you can see that about 30 to 50%. And what does it mean? It means that the cardiovascular mortality in these patients is extremely high, actually. So there is an increased mortality associated with heart failure in patients of chronic kidney disease. In patients of chronic kidney disease, especially in diabetic nephropathy, irbesartan was used in IRMA trial, and you can see that it was effective in reducing the primary composite outcomes in comparison to to amlodipine or placebo. And you can see that doubling of serum creatinine and the incidence of end-stage renal disease, although the death from any causes was not any different in irbesartan versus amlodipine or placebo. In the renal trial, also losartan was compared, and this also showed that the primary composite renal endpoints were lower in patients who were on losartan, doubling of serum creatinine and end-stage kidney disease, also 16% risk reduction in renal trial. In the heart failure patients solved using enalapril, there was a 16% risk reduction, which was highly significant. And in the CHARM trial, candesartan, an angiotensin receptor blocker, 30% relative risk reduction of cardiovascular death or hospitalization for heart failure in these patients. So ACE and ARBs remain the primary drugs for treatment of chronic kidney disease, especially diabetic kidney disease, as well as for heart failure. So these are grade 1 kind of recommendations for treatment of heart failure. Now, what is the effect of RAS inhibition in patients of chronic kidney disease and all? So there are two adverse effects which doesn't allow nephrologists to use RAS inhibition to a complete effect in patients of renal disease. One is the fear as well as the appearance of hyperkalemia in these patients, and the other is a sudden decline in kidney function sometimes, and maybe it's fear of increased hyperkalemia when the renal failure is fairly advanced. And this is the slide which shows you that substantial proportion of patients who had changes with RAS inhibition doses following elevations in serum potassium concentrations. And you can see that in mild hyperkalemia, 50% of patients were able to maintain the dose. Otherwise, the physicians either down titrated the dose or discontinued the dosages in moderate to severe hyperkalemia. So presence of hyperkalemia doesn't allow nephrologists to use these agents effectively in patients of chronic kidney disease. And you can see that. And what is the impact of lower usage of, or not being able to use RAS inhibition completely, is that you can see that the mortality in patients where you are able to use maximal doses of ARBs or RAS inhibition, the mortality is lower. So obviously with lower doses of RAS inhibition, the mortality remains high. So you're not able to take the beneficial effects of RAS inhibition in patients because of hyperkalemia. So there is a need for a drug which will allow us to use these drugs and also help us to manage hyperkalemia in these patients. The paradigm trial, which I was talking about, is the trial which was done in heart failure patients. And this was using sacubitril with valsartan combination called Vimada. It was a Novartis supported trial. The patients were ejection fraction less than 40%, then NYH class 2 to 4. The NT-proBNP was more than 600, and in 1/3, this was lower. Any use of ACE inhibitor or ARB was allowed in this. In fact, the comparator arm was the ACE inhibitor or an ARB in this for about enalapril, which was 10 milligram for at least 4 weeks. And the systolic blood pressure more than 95, eGFR less than 30. So they did not include patients with eGFR less than 30 ml of GFR. And what did you see? You can see the impact of ARNI on the cardiovascular death in patients with heart failure. And you can see that there was a 20% decline in the cardiovascular mortality in patients. The number needed to treat to produce this effect was 31 patients. Now, what is also seen is that death from any cause was also reduced by about 16%, and number needed to treat was 36 in this patient. So the comparator arm was an angiotensin receptor blocker, which, as I showed you earlier in the SALT and the CHARM trial, produced a beneficial effect of about 15%. The comparator of impact on the cardiovascularity of 18%, the neprilysin, the RNA produced additional 20% reduction in death. So overall beneficial effect, in fact, is about 38% reduction in mortality with RNA when you compare it with an ACE inhibitor. So that's the reason cardiologists are extremely excited about this product and started using this product in patients of heart failure. And I can tell you that having worked in a very busy heart center, you found that many patients who were put on the list improved their ejection fraction to such an extent that they were taken off the wait list for heart transplantation. So that's been the kind of excitement with the cardiologists. Even the mode of death, sudden cardiac death, decreased in these patients, and their hospitalizations also decreased with this. So first hospitalization decreased, as well as in you can see that this was a change from the baseline of, and you can see that there was a progressive decline, much greater decline with sacubitril valsartan in these patients, 29% greater reduction with sacubitril. I talked about the impact on hospitalization. This was 40% reduction in the first hospitalization, and cumulative number of hospitalizations also decreased. And that's one of the commonest complications of heart failure, is that patients get admitted again and again into the hospital for fluid overload and heart failure, acute heart failure episodes in these patients. And you can see that how do you titrate these drugs, actually, especially in patients with renal failure, more than 100 systolic, and then you can stop the ACE or the ARBs that the patients may have been earlier, and then give them a washout, the ARNI, and start with a smaller dose, especially in patients where they have been recently admitted with heart failure, and then they are on large doses of diuretics. So there is a possibility that if you start with regular doses of about 100 milligram twice, and then up titrate to around 200 BD, then you may have hypotension in these patients in volume, and sudden decline in kidney function also might happen in these kind of conditions. So therefore, you should start with a smaller dose, maybe 25 milligrams, and keep on going up and up on a weekly basis. And there is a pioneer trial which also looked at use of these drugs in patients before they leave the hospital, after having been taken care of acute heart failure. Previously, this drug was used once the patients were outside the hospital and then had some period out of it. But the pioneer trial again established that you can use these drugs just before they are leaving the hospital, check them for another 2-3 days, and then keep on up titrating the dosages, and that prevents their re-hospitalizations much more effectively. The adverse effects are predominantly one, that this can be hypotension, especially in patients where there is volume depletion. And that, as nephrologists, I don't think I have to tell you that whenever there is a volume depletion, we've told our patients that they must, maybe whenever there are sick day rules for use of ACE and ARBs, and that's whenever there is diarrhea or volume depletion, vomiting or fever or hypotension, then they must stop this drug for a few days. And same should be the kind of education we should be given to patients who are using ARNI. There is obviously some elevation in creatinine, which happens with ACE and ARBs, and we have all learned how to use this drug in these patients. the same effect does occur in ARNI as well. There is hyperkalemia, and I don't think that nephrologists are too much worried about hyperkalemia. They do know how to manage it effectively, and I think they should be able to use this drug. And there is less hyperkalemia with this drug, and this is shown in this slide, that these are patients who had also an MRA at the baseline, and you can see that with sacubitril, the incidence of hyperkalemia was lower in patients. There is also decrease in albuminuria in these patients in the paradigm heart failure trial, and that's not surprising because valsartan and all the angiotensin receptor blockers as well as ACE inhibitors do reduce albuminuria. The initial decline in GFR is known, and that happens much more in patients with volume depletion. But when one looks at the chronic decline in GFR in patients of chronic kidney disease with ACE inhibitors or ARBs compared to the ARNI, it was seen that the decline in GFR was lower in patients on ARNI in comparison to enalapril. And this was 1.61 ml per 1.73 meters square per year, which was significantly lower in comparison to 2.04 ml per 1.73. And this is shown in this curve, that the blue line is the sacubitril valsartan, and you can see that the decline in this is lower than you see in the enalapril. And this is the incidence of impairment of renal function was 3.3% with sacubitril and 4.5%. Significantly lower reports of increase in serum creatinine with ARNI in comparison to enalapril. And in diabetics, actually, you can see that the non-diabetics are in the blue line and in the diabetics are in the red line. And you can see that the diabetics had even a better eGFR trends with ARNI in comparison to enalapril in comparison to non-diabetic patients. Now, if one looks at all the therapies which have been recommended for heart failure, you can see that the relative risk reduction with ARNI is about 28%, with beta blockers 35%, aldosterone antagonists 30%, SGLT2 inhibitors about 17%. And Dr. Kuller is going to talk about the SGLT2 inhibitors also, which although was considered to be an anti-diabetic drug, but has been taken over by the cardiologist as the drug for heart failure. Although SGLT2 inhibitors also have very, very beneficial effects for progression of kidney disease as well. And I think that's why the nephrologists also seem to be very excited about this product, because there are not many drugs which can improve progression of kidney disease. And this seems to be one similar drug. So you have all these drugs. And if you see the combined effect on the mortality and the absolute risk reduction is about 25.5%, and number needed to treat is 3.9 in this. And this is a slide actually which I added yesterday only, and Dr. Narula, who had put it on the Twitter, and I saw it and I thought that I should add it to show that actually there is a lot of drugs which have been used for heart failure, and that's changing the clinical paradigm for management of heart failure in these patients. And ARNI has added a significant amount of risk reduction in the mortality in these patients. And these are all hard endpoints when one looks at the mortality. So the cardiovascular mortality and the overall mortality is reduced, and the number needed to treat if you have a combined all these therapies, which must be used in patients with heart failure, because that remains the commonest cause of death worldwide. Number one cause for death remains cardiovascular mortality, and of which heart failure remains the most. So I would like to sort of conclude that angiotensin receptor neprilysin inhibitor should be a preferred option in comparison to ACE inhibitors or ARBs in patients with heart failure and chronic kidney disease. Now, in the paradigm trial, they did not take patients below 30 ml of GFR. Now, UK HARP study, which included smaller number of patients, was published in Nephrology Dialysis Transplantation, I think in 2019. and that showed that this drug, although did not produce beneficial effects as far as kidney function is concerned, but it probably decreases the cardiovascular death in these patients. So even in patients with stage 4, it was safer to use this drug. They did not have any significant greater, and many of our patients, even on dialysis, are on ACE inhibitors and ARBs. At least I have a significant number of patients who are on ACE inhibitors and ARBs, even in the dialysis, just to prevent cardiovascular complications as well as cardiovascular mortality in these patients. Once in a while, you will have some patients who have significant hyperkalemia or difficult hyperkalemia to manage. But that number, when you look at the study also, is less than 5%. So hyperkalemia should not worry so much. You must monitor for hyperkalemia in patients, and occasionally you will have a difficult patient where you may not be able to use it. But in vast majority of patients of chronic kidney disease and heart failure, we should be able to replace ACE or ARBs with ARNI. And I think we need greater studies in this fashion. And I think nephrologists should also get interested into this molecule, because heart failure in our patients is fairly common, gets not diagnosed. I think it is underdiagnosed in our patients. And I feel that we need more data of our patients and more studies in this patient's population. I think there is a need for coordination between a cardiologist and nephrologist in the treatment of management of especially HFrEF. But I must say that this product was also used in HFpEF. It did not show any mortality benefit in HFpEF as yet. So we are awaiting SGLT2 is also being studied in these kind of patients. So we will await more data in this group of patients, and especially with SGLT2 in CKD population being also non-diabetic CKD population also showing effects. I think we must keep tuned to new information about both ARNI as well as SGLT2 inhibitors, because these seem to be the molecules of 2020. And I think in next 3 to 4 years, we will have a lot more to listen to. Thank you. Thank you very much for your patient hearing. Hello.
Yeah, we can hear you.
Thank you very much, Professor Kher. Okay. For a wonderful talk on ARNI, a lot of questions have started appearing, whether it can be used in patients with preserved heart function, whether beta blockers are this. We will put the questions in the end. Now, can I request you, Professor Kher, that if you can now take over as moderation and introduce Dr. Prateek Das and take ahead?
It would be a pleasure for me to introduce Dr. Prateek Das. Dr. Prateek Das is a consultant nephrologist working in R&D, and he has a vast experience of kidney transplantation and has been presenting on ABO incompatible transplants and large experience in that. But I think he is very active in teaching DNB students as well as an active clinician. He is a fellow of the American Society of Nephrology, fellow of Indian Society of Nephrology, and I know that I was the chairman of the scientific committee when we gave him the Bansal oration, and he was one of the orators for Bansal oration of the Indian Society of Nephrology. Dr. Prateek Das is going to talk about acute kidney injury, the challenges and diagnosis and management. And Dr. Prateek Das, it will be a pleasure to listen to you. Prateek, all yours. While Prateek,
hello.
Prateek.
Yes. Thank you, sir, for your kind note. And today evening, I will be talking something about acute kidney injuries, some challenges and advances. And am I audible?
You are audible.
Yeah, yes, challenges and advances. But what acute kidney injury advances in the last few decades has been in the conceptual level, not that a new molecule has come, a new
Sir,
treatment modality.
you'll have to share your screen.
Okay, can you see the slides?
Yeah.
Yes.
So in next few minutes of time, I'll be talking about some changes in the recent advances in the treatment of AKI. But that will be like that. It is mostly the changes have been made in the conceptual or in the understanding level, not that a new molecule has come or a new mode of therapy has been started and that has revolutionized the management of acute kidney injury. But so there will be something old and something new, and why there is new and old is not acceptable. I will be talking in that way.
You have to move the.
So traditionally, acute renal failure, we call it an acute renal failure. Traditional disease is considered to be an hemodynamic disease that is due to the abnormalities of the systemic hemodynamics with poor intrarenal microcirculations with some precipitating factors that leads to oligoanuria, and that is fluid responsive and sometimes of a severe and requires dialysis and usually recovers after some weeks with a significant mortality. That is a traditional way of thinking a disease called acute renal failure. Today we call it an acute kidney injury. So the treatment plan in the different countries has been mostly based on the restoration of the hemodynamics by using the different kinds of fluids, maybe a crystalloid, maybe a colloid, maybe in the blood. And the recommendations came after few decades of the few decades or even a century after the disease. We have known that the fluid is good for these patients, and in cases crystalloids are better, but with minimal explanations or minimal rectifications in the quality of the fluid and the quantity that should we give. And due to that, due to lack of this, even the small recommendations for over decades, so the mortality of acute renal failure has not been changed over the decades. You can see that since 1960s to 2000, the incidence has been increased, but the mortality due to acute kidney injury has not been changed. So now we know that this treatment it is a hemodynamic disease and fluid is the main part of the treatment, and these colloids are bad and crystalloids are good, and if you give them, sometimes you do some harm, sometimes you do some benefits. But first, that now it is known that even if the colloids are even maybe good and the crystalloids may be bad also. Like this study, which first advised us to use the albumin for the control of this hemodynamics or the restoration of the fluid deficits in the way back in 2004, which showed that there is hardly any difference in the number of the days spent in the ICU, in the hospital, or in the mechanical ventilation if you use a colloid like albumin in place of a saline. But sometimes they have also taught us that there may be the crystalloids may be also bad. We are using normal saline years together for the restoration of the fluid in the patients of the acute kidney injury. But you know, this normal saline does contain huge amount of the chloride. This is a chloride content is about 154 milliequivalent, and that may cause a hyperchloremic metabolic acidosis, and that has an adverse outcome over the over time, especially in the critically ill patients. So there has been always a search for a substance which is more physiological that can produce, that can give a sodium content in the 135 to 145, and chloride content is around 98 to 100. And this physiologically, this plasmaloids, so the physiologically based solution has been studied in several studies with a significant is a well randomized control trial, and that have told that these balanced colloids, crystalloids may be a more superior fluid in terms of replacing the fluid deficits in the patients of the acute kidney injury. And you can see that's then corroborated by subsequent trials You can see that if we use this balanced fluid in place of a normal saline, the chances of mortality is less, chances of new RRT is much less, and chances of death is less. And that has been substantiated by the subsequent studies. So this is the fluid in terms of the quality of the fluid today. In that day, when there is any deficit and we want to plan, we are planning to replenish that amount of the fluid. That is a balanced crystalline solution, may be the best one for this purpose. But how much? The quantity of the fluid direction came through this very encouraging trial in the beginning of this century, and that was an early goal-directed treatment for the fluid replenishment for the patients who are in the septic shock or a systemic inflammatory response. And they told that yes, give more fluid to achieve a target, and that is good. And that is a goal-directed to achieve a mean arterial pressure of 65 with a central venous pressure of like this, and a mixed venous saturations of more than 70%. But this early goal-directed, and it has been shown in the studies that it is good. And it is good for everything. It reduces the 28 days mortality, 60 days mortality, and it decreases the organ dysfunction, and is statistically significant. Although this was a single center study, but that has not been reproduced in the subsequent studies. This is another study which is a randomized control trial, is a protocol based, and they wanted to see it whether this recommendation made by the initial trials that has been generalizable or that can be reproduced or not. Interestingly, it has been seen that there has been no difference in between the fluid in between this early goal-directed treatment compared to the standard care or any protocol-based care, and that has been question has been coming to the different corners of the world, and probably they were telling the much fluid may not be good for the patients, maybe in the albumin or in the crystalloids, and this has been substantiated by the subsequent studies which showed that if you give a more fluid, a generous fluid, there is a more possibility of the volume overload, and that can cause an organ dysfunction, and that can cause a more organ hypoxia, and that can cause a more death. So the fluid accumulation and survival recovery of the kidney function in the critically ill patients in the acute kidney injury that has been published in Kidney International, they have been shown that the patient who survives, the survival rate in the patients who have a fluid overload is much less compared to the patient who don't have this fluid overload. So the conceptually these things has been changed, and it has been shown that this fluid replenishment should be graded or staged in 3 parts. In the initial resuscitation phase, you can see there the target is a patient who are deficit of the fluid, they have a deficit in the fluid in the body. Here the resuscitation phase, you have to preserve this organ hypoperfusion, you have to improve the tissue oxygenation, and you have to restore the volume, so that in that time slightly liberal fluid intake is good probably in those situations, taking care that once you reach the goal, please do not give more fluids for that, because you have probably reached in the maintenance phase. The idea of the maintenance phase is that the intravascular volume homeostasis, in this phase you should not increase the volume, you should maintain the homeostasis in the body, so that in the subsequent phases the volume overload doesn't develop. And in the third phase, when you are planning, when you are expecting a recovery of the patients of the acute kidney injury, in those situations the fluid volume excess can cause more harm than benefit. So in those cases, actively or passively fluid removal the more important. So this is a newer concept that you have to give the fluid, you have to liberal sometime, you have to maintain sometime, but you should not make the patients a volume overloaded. That will increase the organ hyperperfusion and the death. So margin of safety is very narrow when there is and the optimal fluid choice is very important in this group of patients. You can see. So if we take see this, you can see that if you give a slightly more albumin and a more balanced fluid and give in a moderate amount to show that you should not produce hypervolemia, you can be a gainer in terms of managing an acute kidney injury, so that the survival can be improved. But is it so that when we achieve a mean arterial blood pressure of 65 to 70, that is good enough? That will give you the best result. There's a comparative study between this study came after that. It is known that you cannot give more fluid to improve your mean arterial pressure. You have to add something. Whether this high mean arterial pressure is better than the low mean arterial pressure. So this is 80 to 85 compared to 65 to 70. And in a subgroup analysis with the group of patients, especially the patient who had hypertension previously, it has been shown that there is a significantly less renal replacement treatment that is required in the patients who have a higher, this is a mean arterial pressure. So that is a newer concept. So in those situations, those situations, vasopressors can be done, and you know that dopamine is bad, and the most commonly used is the norepinephrine or the vasopressin. But the newer concept is that the outcome, this is a study, this is a subset analysis of the ATHOS-3 study that shows that outcome in the patients with a vasodilated shock in a renal replacement treated with intravenous angiotensin 2. Angiotensin 2 is a potent vasoconstrictor, and you can see that in this group of patients, they concluded that they compared it with a placebo, not with the norepinephrine or the vasopressin, and they showed that in patients of AKI treated with renal replacement treatment, chance of liberalization from the renal replacement therapy is much more if you treat them with angiotensin 2. So initially there is a fluid, subsequently there is some amount of the vasopressor, so that the hemodynamic part of the body is taken care of, and that can should improve the survival of the patients in this group. And this concept holds good still.
I think we have lost
Pratik.
Pratik connection, sir.
Pratik, I think we've lost him.
Yes, sir. We have lost his connection.
Naveen, can you request him to rejoin?
Is he going to get his network back, or?
I'm just calling him, sir.
Yeah.
Otherwise, I was thinking that we could ask him to maybe complete it later after, because
Correct.
we already quite late.
Fine, sir. Please go on, sir. I think his number is not picking up.
Yeah, but you'll have to remove his slides from the share screen.
It's already removed. It automatically
Yeah,
connection.
maybe I think we could ask. You can leave a message for him that he could complete his slides maybe later, and maybe we request Dr. Khullar. Dr. Khullar, are you ready?
Yes.
Yeah, maybe we could ask Dr. Khullar. And Dr. Khullar, actually, he doesn't require any introduction. He is extremely well known, very, very dynamic nephrologist. He's the chairman and head of department of nephrology at the Max Hospital, Saket in Delhi. And he is hugely popular speaker, extremely busy clinician who does everything in nephrology. He is very good in transplantation, dialysis, newer modalities of dialysis like hemodiafiltration and CRRT, and he's been active in managing COVID patients as well. So Dinesh has a lot of academic excellence as well, and so he is a complete nephrologist in my sense. And so Dinesh is all yours. He's going to talk about the SGLT2 inhibitors, which is again another new, interesting, very exciting molecule. Yes, Dinesh.
Thanks. Thank you very much, sir. And thank you so much, first of all, for that very kind and generous introduction. And obviously coming from you makes a huge difference, sir. Thank you very much. So without wasting any further time, I'm going to talk about something which is has over the years become very close to my heart, having been associated with few research activities as far as this particular molecule is concerned, that is SGLT2 inhibitors. And we are all excited to know about what SGLT2 inhibitors can actually do, not just to control diabetes, but the way they offer renal and cardio protection. Just a brief introduction. We all know that diabetes is the biggest challenge which we all as nephrologists come across, and obviously 42% of our patients actually have diabetes as the culprit when they land up with advanced renal failure. What is equally important is to know that diabetes, even an early diabetic kidney disease, as you can see here in the yellow line lower down, can drastically shorten the lifespan of a person. About 15 years in men, about 17 years in females. So obviously, it is actually much worse than many of the dreaded cancers as well. So with this background, we also should be mindful of the fact that, yes, I mean, we heard Dr. Kher talk about the famous renal and the IDNT trials, and we were so very excited about what kind of renal protection could the RAS blockade offer to our patients. But obviously, over the years, we realized that, yes, they were very effective tools, but not enough. And we were certainly looking to have something more in our armamentarium. So the question, the moot point is, can SGLT2 inhibitors prove to be the first major innovation for CKD ever since RAS inhibition was introduced towards the end of last millennium? Well, as you can see, not too many trials over the last so many years. We are desperately looking for something meaningful. And yes, Credence last year provided just that. Before we move on further with SGLT2 inhibitors, just to recapitulate everyone's knowledge, which I'm sure everyone in this gathering today has decent knowledge about the way SGLT2 inhibitors work, still as a formality of repeating, we all know that whenever hyperfiltration occurs and then more fluid or more blood is entering the glomerulus, the tubular-glomerular feedback mechanism sets into place, and via adenosine, it causes vasoconstriction and stops the afferent arteriole so that more blood cannot flow into the glomerulus via afferent arteriole. What interestingly happens in diabetes and early diabetes itself is there is an upregulation of SGLT2 inhibitors. So what happens is, because under the influence of hyperglycemia, more glucose delivery takes place to the proximal tubules. Because of the upregulation of sodium glucose receptors, there is more and more reabsorption of sodium and glucose at the level of proximal tubules, and hardly any sodium reaches the macula densa. Macula densa senses it as if not enough is reaching the glomerulus, and it blocks the tubular-glomerular feedback. So the effect of adenosine is nullified. There is afferent arterial dilatation, and more fluid reaches the glomerulus. Now there is hyperfiltration, but there's a catch here. In spite of this hyperfiltration, not much will again reach the macula densa because the upregulation of sodium glucose receptors has taken place, and still there will be more and more hyperfiltration, yet nothing reaching the macula densa, and that is what typically seen as increased filtration when a patient just becomes diabetic and does not have an adequate control over the diabetic status. Now, what typically happens, and that's why we are so excited about this wonderful class of molecules, which is working beyond its role in managing the diabetes, because that's not what we as nephrologists are really interested in. Of course, I'm not saying that we don't want our patients' diabetes to get controlled, but what we are looking at is something beyond that. And what is beyond that is, because of the blockage of these SGLT2 inhibitors, now the increased sodium and glucose reabsorption is not taking place. More and more sodium and glucose now reaches the macula densa, and macula densa perceives it as a flood which has happened, and now there is a restoration of tubular-glomerular feedback via adenosine. There is an afferent arterial constriction and not much of blood can flow into the glomerulus. So very exciting, and that's what we were told it's the way which happens. But every day, mind you, we are coming across a new and new concept by which SGLT2 inhibitors are working. Now, what I have told you is something very basic and something actually which has been found to be the case in type 1 diabetics. Now, very interestingly, Kidney International last year had an article by Baumel et al. Which talked about the RED trial, and what they showed was there was not an increased renal arterial resistance. What they showed was, of course, there was a reduction in the glomerular filtration under the influence of SGLT2 inhibitors, but this was not the way it happens in type 1 diabetics. In type 2 diabetics, it is something different because they could not prove afferent arterial vasoconstriction. What they showed was there is actually an efferent arterial vasodilatation. So this way, SGLT2 inhibitors were probably working akin to the way RAS blockade happens, exerts its influence. So I think a whole lot of interesting things which we are going to know about SGLT2 inhibitors, and this is what I'm going to talk about over the next few minutes. Well, just to summarize, as you can see on the left-hand side, on the top are the main ones, the increase in the afferent vasoconstriction and a reduction in glomerular hyperfiltration. This stabilizes GFR, causes a reduction in blood pressure because there is a natriuretic effect of this class of effects of drugs, and there is a reduction in albuminuria, and so you can expect a reduction in the interstitial injury as well. There is a reduction in both glomerular as well as tubular injury, and there is also an interesting concept by which they cause an improvement in the hemoglobin, because it's believed that they restore back the function of neural crest-derived fibroblasts, which got converted into myofibroblasts. And once you give them SGLT2 inhibitors, the function of these fibroblasts come back and they start producing erythropoietin in response to tissue hypoxia. So this may be just the few, and obviously we are probably going to learn much more about the way these impressive class of drugs work. Well, what has been shown is that they cause an improvement in albuminuria in patients with type 2 diabetes and hypertension over and above the RAS blockade. As you can see here, if these patients were given just RAS blockades in the gray line, and now if they're given SGLT2 inhibitors, you can see a further improvement in close to 24% in these patients. Well, the first thing which actually rekindled my interest in the field of SGLT2 inhibitors was actually the EMPA-REG trial, which of course, as we all know, was a cardiovascular outcome trial, and so was the canvas shown on the right-hand side. Because all this while, these trials were being driven by the endocrinologists and the cardiologists, and they were wanting to know what happens with the use of SGLT2 inhibitors when they use them with people with significant heart disease, and they were deliberately excluding people with significant renal impairment. And obviously, we were the losers because we had no data to know as to what happens if we were using this class of drugs in people with more advanced renal failure. But let's first look at what they showed in context of cardiovascular outcomes. As you can see, they show some reduction in the GFR, which is quite obvious and logical, and happens in the first month itself. But as you can see, as the time passes, it stabilizes, and over a period of time, it stays there, or to the contrary, in few subsequent ones, you can see they could actually be showing some improvement. While what happens with the placebo arm is they may not have shown the initial decline, but over a period of time, the GFR falls. The same was seen in canvas, but now if you look at the comparison, and the comparison of all of these, be it EMPA-REG or canvas or declared TIMI, all of these were actually cardiovascular outcome trials, which included people with fairly preserved EGFR, but they of course had some degree of either micro or macroalbuminuria. But one thing they told us, and especially highlighted by EMPA-REG, that everyone started taking notice of what post-hoc analysis of EMPA-REG showed, that it may be good for the heart, but it probably is even better for the kidney. As you can see in these cardiovascular outcome trials, a hazard ratio of 0.54, 0.53, and 0.60. So implying 40 to 50% risk reduction when you used SGLT2 inhibitors with people with some cardiac diseases, but not very significant kidney disease. And then comes the data which we were eagerly waiting for, and that's Credence last year, which had included people with GFR as low as 30, with albuminuria between 300 to 5,000 milligrams, and equally impressive, I would say, because hazard ratio here was 0.66, indicating 34% risk reduction with the use of SGLT2 inhibitors as far as the composite endpoints. Then when we talk about the composite kidney disease endpoints, it is basically the doubling of creatinine or at the same time GFR falling to less than 45, end stage kidney disease or renal death. And if you look as is seen here, you pick up any of these trials, whether the cardiovascular outcome trials, the three famous ones with each of these individual molecules, that's CANA, DAPA, and AMPA, or when you compare it with people having more advanced renal disease with CANA as in Credence, you can see this forest plot shows you that every component of the primary endpoints was significantly improved when we had used SGLT2 inhibitors. Equally interesting is to note that the reduction in the risk of these composite kidney disease was regardless of the baseline urinary albumin creatinine ratio. So at whatever stage you choose to use SGLT2 inhibitors, whether your patient's ACR is less than 30 or between 30 and 300 or more than 300, as again in this forest plot, you can see a very impressive improvement with all except for this aberration as was seen in Canvas program, whereby there was only one of the parameters. Otherwise, as a class or across the albuminuria, these drugs showed very impressive data, and this was also regardless of the baseline EGFR. Of course, we have seen over a period of time that if you start early, you are going to get more benefits and more impressive results with the usage of SGLT2 inhibitors. But even more advanced chronic kidney disease, as was seen with Credence, even when the GFR was between 60 and 45 and 45 and 30, you could see impressive results which could be shown with the usage of SGLT2 inhibitors. Now, what you need to see here again is that SGLT2 inhibition stabilize EGFR, and this was seen across the trials. As you can see, there may be an initial reduction, which I had alluded to a short while ago, but one need not be scared because we have enough data that initial reduction in the GFR is not a persistent reduction, stabilizes, and at the end of 3 years or 3.5 to up to 4 years, as was seen in these various trials, you could see a stabilization of GFR or even an improvement in the GFR, contrary to what you would expect to see in people who were receiving placebo. Now, these were the trials in a very strict environment. And the CVD Real 3, which was a real world type 2 diabetic population, also showed us the same. As you can see in the dark blue lines, the SGLT2 inhibitors used at 0 month resulted in significant reduction in initial GFR, which stabilized. And when you compare it with the sky blue or the light blue other glucose lowering drugs, as you can see, they may not have shown the initial abrupt decline, but look at where they were at the end of 24 months compared to where SGLT2 inhibitor receiving patients were. So very interesting things. Now moving the topic a bit further and let us try and see, was it all related to hyperglycemia control? Well, the answer is no, because we all know that SGLT2 inhibitors offer renal and cardiac protection via mechanisms other than or beyond hyperglycemia control. Onto the left-hand side, what we are trying to show is that even when SGLT2 inhibitors were started in people who had glycosylated hemoglobin less than 7%, which means we were not looking at any further improvement in the glycemia control. You can see what canagliflozin had done, and the reduction in the GFR was 2.3 per year as compared to the placebo, which was 4. And on the other hand side, if the HbA1c was more than 7, obviously it was a little more impressive, but then it was the benefits were seen regardless of the glycemia control. So obviously we are excited as nephrologists the way these class of drugs have shown their benefits. Now, very interesting, and this was seen in all the cardiovascular trials, that what I've already shown was very significant, also seen in declared TIMI, that the difference over a period of time was statistically significant. Now, with this, we move on to the next and shift our gears, and we wanted to know all this time as to what do these drugs do in people with more advanced renal disease, and that's what Credence showed us. As I've already mentioned, that Credence included people who were type 2 diabetics with an HbA1c between 6.5 and 12%, and EGFR between 30 and 90, and albumin creatinine ratio of 300 to 5,000 milligrams. And you look at the impressive data, you pick up any, whether it's a primary composite time, outcomes, doubling of serum creatinine, end-stage kidney disease, renal death, or cardiovascular death, everything got benefited with the usage of SGLT2 inhibitors. Now, if we look at, you further subdivide these people who were into the Credence trial, and they followed those people who had initial less than 10% decline in the GFR, 10 to less than 0%, or they had no, rather an increase in the GFR. And if you follow up all these patients over a period of time, 42 months in this case, they had shown that the GFR remained constant. But interestingly, it was also shown in the placebo arm. So what was the difference between the two? Well, as you can see here, the canagliflozin arm, the reduction in the GFR was far less as compared to the placebo arm, even though it remained constant when you compared people who had a significant reduction in the GFR initially or not so significant reduction. Changing the gears even further, as you can see, and I showed earlier that diabetes is the biggest problem which our patients experience. As you can see, 42%. But equally important to understand that 58% of our patients are not diabetics. So how do SGLT2 inhibitors help those patients? Well, we all know that SGLT2 inhibitors have a very impressive effect of lowering body weight, and as you can see here on the left hand side, they cause a reduction in the systolic blood pressure as well as cause uric acid reduction. And if you look at the estimated GFR, this is where we are in terms of comparison with placebo. Now, with this, a diamond trial was shown, and all this were very nicely alluded to and discussed in the recent ERA EDTA over 2 webinars. One conducted by Dr. Tuttle et al., where Dr. Heerspink, who has spearheaded many of these trials, was there as well, and another spearheaded by Dr. Rimouzi and others. So very interesting data which came from Diamond trial, where they wanted to show whether over a period of 6 weeks, a double crossover trial, initially dapagliflozin, then placebo, or vice versa, they wanted to show whether there was a decrease in 24-hour proteinuria. As you can see, hardly any, but this was only over a period of 6 weeks. Not there was a significant reduction in the body weight as compared to placebo. There was reduction in blood pressure, although that did not achieve statistical significance, but hardly any difference in the HbA1c. So again, proving the point that the effects were not related to control of glucose. But what was shown here was that there was a reduction in the.
You will have to.
Yeah, just
very late.
Minute, sir. So as they could show was that there was a reduction in GFR, measured GFR, thereby implying that you can expect a similar kind of effects in people who are not diabetics. And with this background, we had finally the DAPA-CKD trial, and I'm proud because this is very close to my heart, being the national lead investigator for this trial. And here we went one step further by including people who had GFR as low as 25 and an albuminuria between 200 to 5,000 milligrams. And as you all know, that this is the first renal outcome trial which set about investigating the efficacy and safety of SGLT2 inhibitors in patients both with as well as without type 2 diabetes. So 30% of people recruited in DAPA-CKD were non-diabetics. They were hypertensive or albuminuric. And we wanted to know whether, as was shown in the DIAMOND trial, whether SGLT2 inhibitors have equally profound effect in people who are non-diabetics, who have IgA nephropathies or FSGS or hypertensive nephrosclerosis. So, as you know, DAPA-CKD trial was stopped early due to overwhelming efficacy, and obviously we all know that something very positive is going to come out of it very soon. Over the next few months, we will have the results out, and probably it will again change the way we are going to treat our patients with kidney disease who are even non-diabetics. EDTA has these recommendations, and they have very prominently placed SGLT2 inhibitors. And to summarize, CKD is increasingly prevalent and is affecting productive years of life. SGLT2 inhibitors have consistently shown a reduction in renal outcomes like decline in kidney function or progression to end-stage kidney disease, albuminuria, and or renal death, and various mechanisms which I tried to show today. We had impressive data come out of Credence trial last year, and we are eagerly awaiting for the results of DAPA-CKD, which are going to be out over the next few months. Thank you very much.
Thank you, Dr. Khullar, for a very elaborate discussion about the SGLT2. I'm sure I would suggest that please keep tuned. SGLT2 inhibitors are going to throw in a lot of more information, and as Dr. Khullar said, DAPA-CKD, again, very, very interesting. So we should be waiting for that. I don't know if Dr. Pratik, is he ready to complete the slides, or would we go with the discussion? Dr. General Narula? General Verma? Sorry, General Verma. General Verma is also.
You have to unmute, then you can speak, sir.
Yeah, I think we will request Dr. Pratik, because we have overshot the time, that if there are any important messages you can give. Dr. Pratik, I think we can start with you, because you are in between lost. What will be the measures to prevent development of end-stage kidney failure in patients of AKI? Because we know today that patients who require dialysis, almost 14–15% of these patients are going to develop end-stage kidney failure. Is there anything new how we can prevent the development of end-stage kidney failure?
Basically, nowadays, we are aware that this acute kidney injury is mostly due to the apoptotic injuries of these tubular epithelial cells. And this extent of the injury actually determines how much will be the recovery. If the injury is less, then the repair is also complete. If the injury is more and lethal, there is a more invitations of the inflammatory markers, and there is a possibility of the permanent loss, and there will be some amount of the loss of GFR, and a patient will develop ESKD or some amount of CKD or the ESRD. So for that, it is important to there is a concept that has been given by the KDIGO that we call it an acute kidney disease. That means an injury stage that we have to prevent from the injury stage to development of disease. That means a permanent and established amount of the kidney injury is there. So to convert this, we want to avoid this conversion to this acute kidney disease. In that cases, other than this hemodynamic stability in a scientific way, we can also stratify the risk, especially in the acute kidney injury that develops post-operatively, post-cardiac surgery, post-chemotherapy, and this post-surgical cases, other than the sepsis cases. In those cases, we have to stratify the risk, and accordingly, we have to maintain the hemodynamic status in that way during these procedures by maintaining a good amount of the sodium chloride, bicarbonate acidosis in that way, so that this permanent loss and acute kidney disease doesn't develop. In spite of that, there will be some amount of the loss of GFR will be there. That is an inevitable. And in those situations, there is a post-discharge follow-up. That is another important thing that is very important. And some studies have shown that until other than the general follow-up, if you do a follow-up under a specialized care, according to some fixed guideline, there is a possibility of development of these CKDs or the ESRDs are much lesser. So the concept is that the disease doesn't end at the discharge of the patients or some amount of the development of the urine output. There is always a possibility of developing a recurrent AKI. If the patient is already on CKD, there is a possibility of developing this ESRD in those cases. But unfortunately,
you have given a very important message that cardiologists follow a MI. Almost 80% of the MI cases are followed by cardiologists. Unfortunately, only 10% of cases of AKI are followed by nephrologists. I think that you have given the message, AKI does not finish after discharge from hospital, and these are the people who have to be followed up, and intervention measures should be taken accordingly. They should not be left on them. I will put a question to Dr. Anand. He is sitting for quite some time about this COVID-19 and the peritoneal dialysis. What has been the experience in UK? Because as you said, transplantation is closed, HD centers are packed, people are shifting to peritoneal dialysis. What has been the experience in UK about it?
Thank you so much. I will try my best to summarize this because so much has happened in such a short time, and it was such a steep learning curve when the surge came. We had to get prepared for something we were not prepared for ever. So I will try and answer your question in the steps that you have asked me. So the first is about transplantation. So most transplant facilities in the United Kingdom are linked to major hospital centers. And I have the privilege of actually working in one of the largest kidney transplant centers. We carry out something like 350 plus kidney transplants every year, or we did till last year. So our hospital, when we were preparing for the surge of COVID cases to hit, and because we are a major airport, so there is a lot of international travel that happens through Manchester. So we are second after London itself. So we were expecting quite a large population. So soon after the 25th of March, when the lockdown was imposed, all transplant activity was seized because it was not possible to keep the safety of highly immunosuppressed individuals, especially after initial induction therapy. It would not have been safe. So the service was stood down. I am aware that there were about 4 units in the UK which had geographically a setup that allowed them to continue. And and there are reports of this, that the unit in Belfast actually had the largest number of transplants in the 2 weeks during our shutdown, because all the organs went to them. And they probably in 2 weeks did so many transplants that they reduced their waiting list by 2/3. So it was a big event there. So now in the last 2-3 weeks now, the deceased donor program in our center is back up and running. We have had to reorganize the wards as the surge went through. So many of our wards were converted into COVID positive wards, and many estates considerations had to be taken, and I was certainly absolutely unaware. So it depended on the air conditioning and the air purification systems in the various areas of the building. It depended on the oxygen supply to various areas. So the estates department had to intervene and tell us about which wards could be converted and which not. So now we are back. We have also started our living donor program. So that's part one. The second question you asked was, I think, relating to the peritoneal dialysis and role of PD in COVID. Is that right?
Yeah,
so,
that's right.
So we were receiving direct communication actually from the experience in Italy. And then initially it was completely incredulous. We could not believe most of the news that was arriving. I think the Italian towns the northern part of Italy was completely unprepared to the force. And I think the initial presentation of the sickness was quite severe, and we were unprepared. And some of the messages we received, so there were two messages that we received initially, which turned out not to be the right way to go. The first one was, keep these patients dry. And I think that was a mistake. I think keeping patients dry actually pushed them into AKI. And therefore, all the patients who went on to dialysis or renal replacement actually fared quite poorly. And the second message was early intubation and mandatory ventilation. And again, that sort of so if you went on the ventilator, you spent on an average 3 weeks, and actually you had very poor outcome. So I think the system has learned quite rapidly and quite quickly, and I think we are able to manage these patients much better. And somehow, speaking to my intensivist colleagues, we see that we are not seeing the same severity of things. I think probably it's multifactorial, and people have learned how to deal with this. So when the surge came to London just before the lockdown was implemented in the United Kingdom, actually the disease had spread quite widely, and especially amongst very vulnerable populations. So the lockdown actually stratified people, and so there was a population that was identified as very high risk. These were individuals who were on immunosuppressive medication like solid organ transplantation. And you will see on the website of Public Health England, there are 7 categories of patients who were sent letters directly by the Department of Health, and they were asked to go into a process called shielding. In other words, no contact with outside. They were entitled to continuing payments. They were entitled to delivery of food into their houses. And the next category was social distancing, which I think is something which is very commonly heard of. And that was implemented. However, the disease had spread and intensive care units were overwhelmed. So there were patients who were in ICU on the ventilator requiring renal replacement, but they did not have enough facilities for CVVH and dialysis. And therefore, they were literally forced to implement programs of putting them on acute PD. And we have a lot of expertise down south. And you can see some of these are already published. So I have read articles now published from New York because they were overwhelmed, and of course from London as well. However, the story was slightly different in Manchester in that we are one of the largest NHS trusts in the UK. We had in excess of 110 ICU facilities with renal replacement available. And throughout the surge, we did not require, we managed with CVVH and with intermittent hemodialysis. I provide lead for the PD service here locally, and we considered the option of providing acute PD repeatedly. We do our PD catheter insertions, we could have done those, but I thought that in my mind, it wasn't the best therapy. And if we could avoid PD and deliver adequate CVVH and intermittent hemodialysis, we would probably serve the patients better. When you read these articles about acute PD, please be careful to see the outcome, because a lot of these patients, they say the technique was successful, but the patient was lost. So I think there is a slight, you have to be careful to interpret these.
I think, Dr. Anand, we have got 2 leaders in PD in this webinar only, Dr. Bhalla and Dr. Kuller, they have got one of the largest crowd of PD. I'll take your comments, Dr. Bhalla and Dr. Kuller.
General,
Yes.
General Verma, actually, General Verma, just a minute. Dr. Amit Gupta is in the audience also. He's
He's there.
Yeah.
He is.
So, I will like to share some of our experience related to your talk. One was the straight double cuff catheter versus coiled catheter. In fact, we have used almost 95% of patients straight double cuff catheter, and we are quite comfortable with that. So our experience with straight double cuff catheter was excellent. Second was about peritonitis. You said about cefazolin plus ceftazidime. These are both are useless in our experience because there is a 100% resistance in our cases of peritonitis. Most of our patients require only carbapenem now. So we have to start with carbapenem and vancomycin. So in fact, cefepime we have started using now, but cefazolin and ceftazidime both are out. Third was about this, you mentioned about this microsensor device. We have no experience with that. Once it comes to us, then we'll see how it will work. Thank you for your excellent talk.
Dr. Kuller, any comment on PD before we close the PD talk?
No, I think Dr. Bhalla has already said that, but I think I have more experience with the coil catheters of late. I mean, we have moved away from straight and more in favor of coil, and I don't know whether we need to go back to straight any longer.
Dr. Amit Gupta, is he there in the crowd?
Yeah, he was. Yes. I think he put a question.
He was just asking where is Dr. Ram?
Yeah, I'm here.
Yeah.
I'm here.
Yeah, please, Dr. Amit Gupta, please go ahead with your comment.
No, Mike, this thing, our unit is still using straight catheters. We prefer straight catheters because they're less expensive as compared to the coil catheters. And our use of antibiotics for peritonitis still remains vancomycin and an aminoglycoside, either tobramycin or gentamicin. Now, I just asked where is Ram Gokul because he's been visiting India quite often, but we have lost touch with Dr. Gokul. So I just wanted to know if there's any information about him.
May I be allowed to respond?
Yes.
Yeah.
So I replied to your question, Dr. Amit Gupta, and I'm here because of Professor Gokul. I was his last senior clinical fellow and did research with him. And he retired in a very timely because I was around and they couldn't find anybody else. So I got his job. So he has relocated to Canada. And so we are in very regular email contact. Traveling is less, but whenever he comes to the UK, we will meet up. He is in very good health and practicing yoga. And actually, you might see him in some of the channels because
he's a yoga instructor, I'm told.
Yes, and he's actually teaches on Vedic ideology.
And lectures on Vedic,
Yeah, that is.
I visited Manchester about in 1997, and at that time itself, he was very interested and involved with the Hindu temple there.
Yes, that is true. That is true. Can I also just comment on the peritonitis because it is important? I was simply summarizing the research that was presented at the EDTA. In our own unit, especially to Dr. Bhalla, we do not use cephalosporins. In fact, cephalosporin use in the United Kingdom is very strictly controlled because of its complications with CDT diarrhea. And therefore, our regimes involve vancomycin and aminoglycoside. And I think there is infrequent dosing required. There is easier success of therapy. So there are many points which we can possibly discuss, but you're absolutely right. I think these cephalosporin-based regimes, although they came up with the ISPD, I don't think many units follow that. And I think the guidance is to use local sensitivity.
That is the usual pattern in India also. I think we go to SGLT2 and ARNI. After that, I'll request Dr. Kher to take over. Both the trials were stopped in between after 2.6 years or 2.7 years because the outcome was far superior. Now, both the trials took a GFR of up to 30 ml only. Now, the questions from the audience are, you did mention about the DAPA trial, which is ongoing, that possibly you took a GFR up to 25. Now, in pediatric practice, can they be used? Number one. Number two, for Dr. Kher, can ARNI be used even in preserved ejection fraction rather than it has been tried in low ejection fraction? Yeah, these are the two questions which have been, you have already answered that it can be used in non-diabetic renal disease also.
Yeah, I
So-
think, maybe I can take it, and or you can take Dinesh.
Dr. Kher, you can take first. And the first question was, will you like beta blocker as number one, or will you like ARNI as number one?
No, it doesn't matter which one. Actually, you should use combination of drugs because they have different mechanisms of action. And for heart failure, the combined effect produces an absolute risk reduction of about 25% or so. As I told you, that when you combine beta blockers, you use mineralocorticoid receptor antagonists, you use ARNI, you use and SGLT. It's at the moment SGLT2 inhibitors are not combined at the moment, but I'm sure there's going to be data coming of combination of SGLT2 inhibitors for heart failure along with ARNI and all that. That's also going to come. But when you combine these, the absolute risk reduction, as I showed you in the last slide, was 25%. So you should combine the uses of beta blocker as well. So I think the first line of drug I would use would be a beta blocker and add an ARNI to that. In patients with kidney disease, I think the nephrologist where they need to come into this is that in patients where the GFR is earlier, instead of using, say, an ACE inhibitor or an ARB in patients of preventing progression of kidney disease, should we be using ARNI instead? Now, at the moment, I don't think nephrologists are interested because these drugs are expensive still. And there is no trial which has looked at progression of kidney disease in that kind of a fashion. So we don't have good evidence to suggest that, but it makes sense that actually these would be better drugs probably than just using only valsartan or using, say, any other angiotensin receptor blocker or using an ACE inhibitor in those kind of situations. The questions which have come is one, that how frequently should you monitor for potassium when you use this in the population? Every time you are increasing the dose, like we do for ACE inhibitors or for ARBs, we should be monitoring for potassium and kidney function in patients in the early stages of kidney disease. I think that's a question which I saw. What is the cost of this drug at the moment is 70 rupees for a 50 milligram tablet. So it's an expensive drug still because the dosage which is suggested by Paradigm trial is actually 200 milligram twice daily. So it will be an expensive combination of drugs. So, and that's the reason why this drug is still not being used. But it's an extremely interesting molecule, very exciting, showing tremendous effects on mortality, which is the hard endpoint. So that's the reason for interest for SGLT2 and these drugs is because they've changed the hard endpoints of mortality, cardiovascular mortality. And that's the reason why both for SGLT2, even for nephrologists, Dr. Kulla talked about end stage kidney disease. All the make sort of were the items were altered by the SGLT2 inhibitor. So I feel that this would be used in patients with heart failure in combination with all the other drugs that we.
So yeah.
Dr.
So rather than using
another question also for you, they have said that in the comparative head-to-head trial, like you quoted about MREBA and Canvas and Declare, is there any difference in UTI and Fournier's gangrene?
So I'll forget the questions to Dr. Verma. You need to remind me just in case I do that. So first, I think there was an interesting question, and I answering on Dr. Kher's behalf. HFpEF. There were two landmark trials. One was the Paramount trial, which looked at HFpEF, and the other one was the Paragon trial. And I think even though the Paramount trial showed that the longitudinal strain did not improve with ARNI, but the global strain improved. So people thought that maybe it is going to work when have preserved ejection fraction as well. But unfortunately, the Paragon trial just narrowly missed the the efficacy point, and it showed that there was no difference in the cardiovascular mortality or the death rate with the use of ARNI when used in PEF patients. Now, switching gears and then talking about SGLT2 inhibitors. Now, very interesting concept here. And someone asked the question whether they can be combined. Now, let me tell you something which I always was intrigued about. Now, the combining ARNI and SGLT2 inhibitors. ARNI, as you look, is going to increase natriuretic peptides, which means they are going to open up the afferent arteriole. On the other hand, you're saying use SGLT2 inhibitors. Now, this is going to cause afferent vasoconstriction. So you are probably nullifying each other's effects. But all these trials, including DAPA heart failure trial, which was another landmark trial, had included people who were on ARNI and then put them on SGLT2 inhibitors, and it worked very well. So what I learned beautifully from that trial, which I mentioned about the RED trial, where Baumel et al. Showed that the way SGLT2 inhibitors work in type 2 diabetics is probably different. It works like RAS blockers. It opens up the efferent arterioles rather than constricting the afferent arterioles. So that's the genesis of combining SGLT2 inhibitors and ARNI. Coming to the question of the infections seen with dapagliflozin. Well, I think they were overhyped. Whether you talk of fractures, the amputations, the Fournier gangrene, the UTIs per se, I think they were overhyped, and we struggled coping up with these kind of fears initially. But with Credence and whole lot of other trials, it has been shown that yes, genital infections may be little increased in frequency. As far as any SGLT2 inhibitors are concerned, we should not be overly worried about the use of SGLT2 inhibition, even including, as someone asked, whether they can be used in transplant setting. Answer is yes. This is from personal experience. We are using SGLT2 inhibitors even post-transplantation at the moment to look at and to achieve the glycemic control. But I'm sure back of the mind, we are also hoping that it adds value and it offers xenoprotection to our patients of post-transplantation who are all the time bombarded with drugs, including CNIs with the vasoconstriction. And we need drugs like this, which can probably offset many of these. So I think it's an exciting world. We need not be overly bothered about UTIs, but yes, if your patient has recurrent UTI, you're not going to put them on SGLT2 inhibitors. If your patient has ketoacidosis, you're not going to put them on. And obviously, if genital infections are too cumbersome, obviously, again, you may not want your patients to suffer any further and look for alternatives.
Professor Kher, I think you
Thank you, Dinesh, for taking up that preserved renal fungi. I forgot about that, and thank you. That was good. Yes, General.
Professor Kher, you can, I think, conclude if there are any questions. Dr. Bhalla, if there are any comments. Dr. Prateek Das, if there is any comment.
I think we have actually gone overboard by about 45 minutes or so, I think. And I think I must, you will join me in sort of thanking all the speakers for an excellent overview of the topics that you had selected so well, actually. I think all the credit for selection of topics goes to General Verma. He has worked very hard on picking up people as well as picking up the topics out of this ERA EDTA and done an excellent job in. And I must thank everybody else, the audience, including Dr. Amit Gupta and Dr. Vardhan. Excellent talk. I must compliment you. You will get invited. I'm sure Dr. Bhalla has given you an invitation. I'm sure you stood up to the task.
Oh, definitely.
Very, very good. So I must thank you for sparing time for us and giving an excellent talk. And Dinesh, as usual, is brilliant. And Prateek, unfortunately, got stuck because of the internet problems. But then that's the new learning we are having also about that. Sometimes these new modems do not always succeed. They do fail us off and on. And I must, at the end, thank
And I also must say,
Master Raja.
Dr. Kher, you have appreciated everyone. I also must appreciate you for your work.
All of us. All of us, in fact, as there's no second thought about that. Yeah.
So
I really enjoyed
I must thank also
lectures.
Microlabs, Mr. Raja, for giving us this opportunity. You have another day coming up tomorrow as well, which will conclude the 3-day kind of the academic feast that you've been having. With this, I close and I will hand it over to Mr. Raja.
Thank you, sir. I think you've covered the complete the thank you note of mine. And once again, I would like to thank all the course directors, Dr. Vermaji and Balaji, and as well as Dr. Vijay Kher, and for chairing today's session and for facilitating a very nice scientific deliberation. I also thank our speakers, Dr. Anand Vardhan, Dr. Vijay Kher, Pratik Das, as well as Dr. Dinesh Kular, who had spared their valuable time and prepared for today's webinar despite their busy schedules. So on behalf of Microlabs, we really thank each and every doctor for having spared their valuable time helping in this knowledge dissemination. And I look forward to meet you tomorrow for the 3rd day of Annual Congress of Regain by tomorrow, close to about 7 p.m. IST. So until then, thank you, one and all of you, signing off by Microlabs. Thank you, sir.
Bye-bye. Bye-bye.
Thank you. Bye-bye. Good night.
Thank you all.
Good night.
Namaste.
Good
Yeah,
night.
good night. Bye. Bye. Bye.